Hello everyone, I am myself Dr. Rajesh Gubba. In this particular session, I'll be discussing a very important topic in the cardiology. It's a valvular disorder, that is the mitral stenosis. So, mitral stenosis, that is one of the most common valvular pathology among the valvular heart disease which we come across. And before going ahead with the detailed discussion of the mitral stenosis, first you need to know what is the normal mitral valve area. The normal mitral valve area, it is around 4 to 6 centimeters square. Now, in mitral stenosis, what will happen to the mitral valve area? That will be less than 2 centimeters square. That will be the mitral valve area in case of the mitral stenosis. Now, what is the most common cause of the mitral stenosis? The most common cause of the mitral stenosis will be the rheumatic fever, right? And this particular rheumatic fever, in clinical scenarios like chronic rheumatic heart disease, the most common valvular pathology in case of chronic rheumatic heart disease will be mitral stenosis. Whereas in case of acute rheumatic fever, the most common valvular pathology will be mitral regurgitation. But whereas in chronic rheumatic heart disease, the most common valvular heart disease will be the mitral stenosis. Now, what exactly does this rheumatic fever do to the mitral valve or mitral valve apparatus? Let me discuss. Now, first, let me just give you or let me tell you the components of the mitral valve apparatus. Mitral valve apparatus, it has the following components. Number one, mitral valve leaflets. You have anterior and posterior mitral valve leaflet. Then you have the mitral valve annulus in which the mitral valves are being fixed. Then these mitral valve leaflets, they have the commissures. That is, the medial and as well as the lateral commissures are there for this mitral valve leaflets. And these mitral valves, they are connected to the chordae tendineae. And this chordae tendineae, it is connected to the papillary muscles. So these are the structures which are present within the mitral valve apparatus, and these structures are being affected in case of the rheumatic fever. Now, remember, in case of rheumatic fever, there will be inflammation of the mitral valve leaflets, right? Both the anterior and as well as posterior mitral valve leaflets, there will be diffuse thickening of the valve leaflets. And not only diffuse thickening, subsequently as a part of the inflammation, there can be accumulation of the fibrous tissue within the valves. And subsequently, within this fibrous tissue, there can be also calcific deposits as well. So, inflammation, fibrous tissue formation and calcific deposits will be there within the mitral valve leaflets. So, thereby, how will be the mitral valve leaflets in case of the rheumatic fever? The mitral valve leaflets, it will be thick and as well as rigid. And not only the mitral valve leaflets, even the chordae tendineae, they get affected. Now, what will happen to these chordae tendineae is, these chordae tendineae, they get fused and they are also shortened. Right, they are also shortened. And what will happen to the leaflets? These leaflets, they become rigid in consistency. Now, this entire pathological process, it eventually narrows, right? That is, the thickening and rigidity of the mitral valve leaflets, the fusion and as well as shortening of the chordae tendineae. This entire process will cause narrowing of the apex of the funnel-shaped valve, okay? So, there will be narrowing of the apex of the funnel-shaped valve, and this particular narrowing of the apex of the funnel-shaped valve, this will give you what is called as an appearance of a fish mouth, right? This will give you an appearance of what is called as the fish mouth appearance in case of the mitral stenosis. So, initially, right, what will be the initial insult in the mitral valve leaflets? That is rheumatic. Later changes may be inflammation, fibrosis, and then calcification of the valves. So, this will be the effect of the rheumatic fever on the mitral valve leaflets. Now, there are many other etiologies that will be causing the mitral stenosis. It is not only the rheumatic fever. Now, what are the other diseases? The other diseases include the congenital mitral valve stenosis, which I will be discussing that in detail. Then we have quadrature atrium, then mitral annular calcification with extension onto the leaflets. The inflammatory disorders or autoimmune disorders like systemic lupus erythematosus and rheumatoid arthritis, left atrial myxoma, infective endocarditis with large vegetations. Now, let me discuss few points about the congenital mitral valve stenosis. This congenital mitral valve stenosis, right, the pathology within the mitral valve or in the mitral valve apparatus, the pathology could be supravalvular, or the pathology could be valvular or subvalvular pathology, right, or the subvalvular pathology. Now, in the supravalvular area, there will be formation of a membrane, right, and this supravalvular congenital mitral stenosis, this is the component of the Schoen's complex or the Schoen syndrome. I'll tell you what are the components of the Schoen complex. There are totally 4 components, I'll tell you. Then the another form of the congenital mitral stenosis is the pathology being at the level of the valve. The other one is subvalvular mitral stenosis. In case of subvalvular mitral stenosis, there is presence of a single papillary muscle. Right, there is presence of the single papillary muscle, and the presence of this single papillary muscle will give you an appearance what is called as a parachute mitral valve. Right, that will give you an appearance of parachute mitral valve. So this is about your congenital mitral valve stenosis. Now, what are the components of this Schoen's complex? See, Schoen's complex, I said you there are totally 4 important abnormalities. One is the supravalvular mitral membrane causing mitral stenosis. Then there is parachute mitral valve. That means in Schoen's complex, apart from supravalvular, there is also subvalvular pathology as well. And there is muscular or membranous subvalvular aortic stenosis is there apart from mitral stenosis, and there will be also coarctation of aorta. So these are the 4 components of the Schoen's complex, which is one of the cause for congenital subvalvular or supravalvular mitral stenosis. Then quadratrium. Now, what exactly happens in the quadratrium? In this quadratrium, there is presence of a fibromuscular membrane within the atria. Right, so you can see this. So this is the fibromuscular this is the fibromuscular membrane which is present within the atria and this membrane, it is present either in the left atrium or it is present within the right atrium. So if this fibromuscular membrane which is dividing the atria, if it is present within the left atrium, this we call it as quadratrium sinister, and if this fibromuscular membrane dividing the atria is present in the right atrium, this we call it as quadratrium dexter. Right, this we call it as the quadratrium dexter. So these are the 2 important forms of the quadratrium. But between these 2, which is more common, it is quadratrium sinister, which is more common than compared to that of the quadratrium dexter. Okay, right. So this is about your congenital cause. And we have like inflammatory causes which we have discussed. These inflammatory causes are what? There is systemic lupus erythematosus and as well as the rheumatoid arthritis. And in systemic lupus erythematosus, it is not only endocarditis, it is pancarditis will be there. Pericarditis, myocarditis and endocarditis also will be there. And that endocarditis will be in the form of Liebman-Sachs endocarditis, and valvular pathology in case of SLE will be mitral stenosis. And you take in case of rheumatoid arthritis, what are the other cardiac manifestations in rheumatoid arthritis apart from mitral stenosis is, it can there can be premature atherosclerosis causing coronary artery disease. There can be development of constrictive pericarditis, and there can be also valvular pathology in the form of mitral stenosis in case of the rheumatoid arthritis. Then we have one storage disorder which can cause or which will cause the mitral stenosis, and that particular storage disorder, that is nothing but the Hurler syndrome. Right, it is nothing but the Hurler syndrome. So this Hurler syndrome, it is basically a form of mucopolysaccharidosis. Right, it is a form of the mucopolysaccharidosis, and we have multiple or various forms of mucopolysaccharidosis, out of which the Hurler syndrome, it is type 1 mucopolysaccharidosis, and it is a storage disorder. And what type of storage disorder is this? It is a lysosomal storage disorder, and it is an inherited disorder and the type of inheritance is an autosomal recessive type of inheritance. Now, in this lysosomal storage disorder, what is that abnormal substance which gets accumulated in case of the Hurler syndrome? So, it is the accumulation of large sugar molecules, right? And what are these large sugar molecules which will be accumulated within the lysosomes is, that is, the glycosaminoglycans are the one which are accumulated within the lysosomes, and that will be responsible for your lysosomal storage disorder. Next, now this Hurler syndrome, it is mainly due to an enzymatic deficiency, and the enzyme which is being deficient is alpha L iduronidase. Right, alpha L iduronidase, it is the enzyme which is being deficient in case of the Hurler syndrome, causing accumulation of the complex carbohydrate, that is glycosaminoglycans, right? And how do you treat? The treatment is the alpha L iduronidase enzyme replacement has to be done. So, enzyme replacement, that will be the treatment for the Hurler syndrome. Okay, see, it is mucopolysaccharidosis type 1. See, you should not get confused with the Hunter syndrome. See, this Hunter syndrome, that is also a form of the mucopolysaccharidosis, but here it is type 2 mucopolysaccharidosis, whereas Hurler syndrome causing mitral stenosis will be type 1 mucopolysaccharidosis. These are all the etiologies that will be causing the mitral stenosis, right? Now, so among these, the most common cause will be rheumatic fever. What are the congenital causes? That includes the quadriatrium and as well as the congenital mitral stenosis, right? And what are the tumors that can cause mitral stenosis? Left atrial myxoma, right? And what are the inflammatory or autoimmune conditions causing mitral stenosis? That will be rheumatoid arthritis and as well as systemic lupus erythematosus. And what are the storage disorders that will be causing mitral stenosis? That will be mucopolysaccharidosis type 1, that is Hurler syndrome. Now, let me discuss about the pathophysiology in mitral stenosis. See, basically what happens is, as the severity of the mitral stenosis increases, the left atrial pressure increases and there will be backflow of the fluid. So, from left atrium to the pulmonary veins, from the pulmonary veins to the pulmonary capillaries, that can cause pulmonary edema. And not only that, as the severity of the mitral stenosis increases, from the pulmonary capillaries, the pressure is reflected back into pulmonary artery, causing pulmonary arterial hypertension. Once there is pulmonary arterial hypertension, that will affect back on the right ventricle in the form of right ventricular dilatation or right ventricular failure, and there can be even tricuspid regurgitation, but that will be functional tricuspid regurgitation. So all that let me discuss within the pathophysiology. So how much is the normal mitral valve area? That is 4 to 6 centimeters square. When the mitral valve area, if it is reduced to less than 2 centimeters square, we call it as mitral stenosis, and this we call it as progressive mitral stenosis. And if the mitral valve area is reduced to less than 1.5 centimeters square, this we call it as severe mitral stenosis. And if the mitral valve area is reduced to less than 1 centimeter square, this we call it as very severe mitral stenosis. Right, this we call it as very severe mitral stenosis when the mitral valve area is reduced to less than 1 centimeter square. Now, let me tell you what happens when the mitral valve area is reduced to less than 2 centimeter square. That is, in progressive mitral stenosis, what will be the problem? See, in case of progressive mitral stenosis, if at all, if the blood has to move from left atrium to the left ventricle, what the left atrium has to do? The left atrium has to abnormally increase its pressure. So, there should be abnormal increase in there should be abnormal increase in the left atrial pressure gradient, and that abnormal increase in the left atrial pressure is the one which will push the blood from the left atrium to the left ventricle. So, this increased left atrial pressure will create a gradient, and that we call it as atrioventricular gradient. And the development of this atrioventricular gradient, that is the hallmark of the hemodynamics in case of the mitral stenosis. So, more and more is the atrioventricular gradient, more and more severe is your mitral stenosis. And when the mitral valve area is less than 1.5 centimeter square, that is severe mitral stenosis, what happens is the left atrial pressure, it is elevated up to 25 millimeters of mercury. So how much will be the normal left atrial pressure? The normal left atrial pressure will be around 6 to 12 millimeters of mercury. But in severe mitral stenosis, in order to send the blood, left atria has to contract very strongly, right? And thereby the left atrial pressure will be increased up to 25 millimeters of mercury. So this much pressure is required to maintain the cardiac output in case of the severe mitral stenosis. But the problem is that when left atrial pressure, right, when the left atrial pressure is elevated to 25 millimeters of mercury, between the left atrium and pulmonary veins, you don't have any valves. So thereby, this 25 millimeters of mercury pressure which is elevated in left atrium, that will be reflected back into the pulmonary veins. So pulmonary venous pressure will be elevated, and subsequently your pulmonary capillary wedge pressure also will be elevated. And now, once the pulmonary capillary wedge pressure is elevated, the fluid from the pulmonary capillaries will enter into the interstitium of the lung, causing pulmonary edema, and that will contribute to the development of the exertional dyspnea. Right, that will contribute to the development of the exertional dyspnea. So, depending upon the valve area, the hemodynamics or the clinical symptomatology completely changes. Now, what are the parameters that will assess the severity of the obstruction? One important point already I have said you, that is transmitral pressure gradient. So, the transmitral or transvalvular pressure gradient, it is one parameter which will decide the severity of the mitral stenosis. That means it is like directly proportional. More is your transmitral pressure gradient, more severe is your mitral stenosis. And the another important parameter is the flow rate. Okay. Now, this particular flow rate, right, it depends not only on the cardiac output. See, basically, what is that flow rate we are discussing? It is the volume of the fluid which is moving from left atrium to the left ventricle. That is what is your flow rate. So, if the flow rate is grossly reduced, that means it is severe mitral stenosis. Thereby, the cardiac output will be reduced, right? But this particular flow rate is not only dependent on the mitral valve area. Listen this point, it is very, very important. The flow rate from left atrium to left ventricle is not only dependent on the mitral valve area. Upon the mitral valve area, the flow rate, it also depends upon the heart rate of the individual. Right? What is that? More is the heart rate, right? More is the heart rate. What will happen? The ventricular rate is basically increasing. When ventricular rate is increasing, what will happen to the diastolic time of the ventricle? The diastolic time of the ventricle is reduced. Right, diastolic time of the ventricle is reduced. Now, once the diastolic time of the ventricle is reduced, what will happen now? What will be the problem? The blood which has to come from left atrium to the left ventricle during diastole will be reduced. Okay, so the inflow into the left ventricle will be reduced. So once the inflow is reduced, what will happen to the gradient again? The gradient again increases. So once the gradient increases, that will be causing increase in the pulmonary venous pressure, increase in pulmonary capillary wedge pressure, and increase in the pulmonary arterial pressure. So what you have to remember basically is there are two important parameters which are assessing the severity in the pathophysiology. One is transmitral or transvalvular pressure gradient, which completely depends upon the valve area, and next is the flow rate. The flow rate completely depends upon the heart rate of the individual. More is the heart rate, lesser will be the diastolic filling of the ventricle, and this further again decreases the flow rate, that is the amount of the blood which has to come from LA to LV will be reduced, and that will again increase the transmitral pressure gradient. So these are the two parameters which will decide the severity. Now this particular heart rate, in what are all the conditions which can get elevated? One, the heart rate can be increased whenever the individual is doing any exertional activity. So that is the reason why, what is the concept of the patient having exertional dyspnea? Whenever there is exertion, there is tachycardia. So diastolic filling of the ventricle will be reduced. Transmitral gradient increases. That will precipitate the pulmonary edema. And the other scenario where there can be increase in heart rate, particularly in case of mitral stenosis, is in patients with the atrial fibrillation. In mitral stenosis, there is development of a very important complication that is called atrial fibrillation. And in atrial fibrillation also, ventricular rate increases, diastolic filling time decreases, there will be increase in the transmitral gradient causing the pulmonary edema, right? So that is about your pathophysiology in patients with the mitral stenosis. And next important thing you need to know, how will be the left atrial pressure waveforms in mitral stenosis. So the left atrial pressure is increased. So left atria, it requires a stronger left atrial contraction to push the blood into the left ventricle. So thereby, how will be the A wave? You will have a giant A wave, right? You will have a giant A wave. And another important abnormality in the waveform is the Y wave. So if you go back to the JVP, we have discussed in detail about this Y wave. So Y wave, like what it represents the atrial emptying. But how is the atrial emptying here? The atrial emptying is very slow. So that is the reason why even your Y descent will be a slow Y descent. So giant A wave and gradual pressure decline within the left atrium causes the slow Y descent. That is what you will observe the pressure changes in case of the mitral stenosis. Now, how will be the cardiac output in patients with mitral stenosis? It completely depends upon the severity of the mitral stenosis. Okay. So you take severe mitral stenosis where the valve area is around 1 to 1.5 centimeter square. So here the cardiac output will be normal at rest. Right, cardiac output will be normal at rest. Okay, and on exertion what happens? Right, so the cardiac output, it tries to increase subnormally during exertion. So that is the reason why in patients with severe mitral stenosis, when the valve area is around 1 to 1.5 centimeter square, the individual is hardly symptomatic. Right, the individual remain almost asymptomatic. But the problem comes when the valve area is reduced to less than 1 centimeter square. That is very severe mitral stenosis. So when there is very severe mitral stenosis, cardiac output will be reduced at rest. Right, cardiac output will be reduced at rest, and upon exertion, right, upon exertion, right, what did we just discuss? Upon exertion, the ventricular rate increases. So diastolic filling time decreases, transmitral gradient increases. So upon exertion, the cardiac output further reduces. Right, cardiac output further reduces upon exertion in case of the very severe mitral stenosis. So that is the reason why these patients with very severe mitral stenosis, they become easily symptomatic upon exertion, or sometimes they can be symptomatic even at rest. Like for example, a patient with very severe mitral stenosis has developed some infections like fever, right? Or the individual has developed anemia. What happens in fever or anemia? What will happen to the heart rate? Heart rate increases, ventricular rate increases. So diastolic filling time of the ventricle decreases, and thereby, there will be decrease in the cardiac output, and that can make the individual being symptomatic, dyspnea and as well as the fatigue. Now, apart from the cardiac output in the pathophysiology, you need to know that development of pulmonary hypertension. So definitely there is development of pulmonary hypertension in patients with the mitral stenosis. What is one mechanism? That is because of the backward transmission of the fluid. So there is elevated LA pressure. This elevated LA pressure will cause the backward transmission of the fluid into pulmonary veins, pulmonary capillaries, pulmonary arteries, causing pulmonary arterial hypertension. Then these pulmonary arterioles, they undergo vasoconstriction. Why is that they undergo vasoconstriction? Because of pulmonary edema in patients with mitral stenosis, there will be development of the hypoxia. Now, what is the effect of hypoxia on the pulmonary arteries? there will be pulmonary arterial vasoconstriction, and that will result in the pulmonary hypertension. Okay, right. Now there will be the another mechanism for the development of pulmonary hypertension in mitral stenosis is there will be interstitial edema in the wall of pulmonary, right, in the wall of the pulmonary artery. Right, there will be interstitial edema in the wall of the pulmonary artery. So because of the development of the interstitial edema in the wall of the pulmonary artery, what happens? The vascular lumen decreases, and that will cause increase in the pulmonary artery pressure. And at the end, the other important pathophysiology for the development of pulmonary hypertension is the obstructive changes. At the end stage, there will be organic obstructive changes within the pulmonary vascular bed. Right, there will be obstructive changes in the pulmonary vascular bed. Okay, so this is about the mechanism for the development of pulmonary hypertension. Now, once there is development of pulmonary hypertension, what is the effect of severe pulmonary hypertension? That will increase the after node on the right ventricle, and that will cause right ventricular enlargement. Right, and this right ventricular enlargement will further progress to the development of the right ventricular hypertrophy. There can be pulmonary regurgitation. Why? Because of pulmonary arterial pressure, the blood will try to leak back from the pulmonary artery to right ventricle, causing pulmonary regurgitation, and thereby there will be a murmur, and that murmur is called as the Graham-Steele's murmur. Right, which we will be discussing in detail about this Graham-Steele's murmur. And the another point is, because of increase in the right ventricular pressure, the blood from the right ventricle will try to leak back into the right atrium, and that we call it as the tricuspid regurgitation. Okay, and ultimately at one point of time, the individual lands up in the right ventricular failure. This will be the effect of severe pulmonary hypertension, which is caused by very severe mitral stenosis. So now, after having discussed about the pathophysiology, like how will be the symptomatology and how will be the progression of the disease. Now, after the development of the rheumatic fever, right, between the development of rheumatic fever and as well as the development of clinical symptomatology, you have some latent period. Okay, so the latent period between the initial attack of rheumatic carditis and the development of the development of the clinical features, the latent period is almost around 2 decades. Right, the latent period is almost around 2 decades. And these patients with rheumatic fever, they become or they develop disability in 4th decade of life. Right, in 4th decade of life, they become disabled. And if these patients with rheumatic fever, if they are not being treated, right, if there is no like surgical treatment, then within 2 to 5 years, the individual will die. So this will be the progression. After the development of rheumatic carditis, the latent period for the development of symptoms is around the 2 decades, and the individual will become disabled by 4th decade, that is around 40 to 50 years. And if the individual is not being treated after the development of symptoms, right, once the individual has become seriously symptomatic, and if the individual is not treated, then within 2 to 5 years, the individual will have the mortality. Now, what will be the clinical symptomatology in progressive mitral stenosis and clinical symptomatology in severe or very severe mitral stenosis? The clinical symptomatology is very simple. In progressive mitral stenosis, the individual will be asymptomatic at rest. Right, the individual will be asymptomatic at rest, and only there will be dyspnea on exertion. And why on exertion? There will be development of dyspnea. We have just discussed the pathophysiology, right? So on exertion, the ventricular rate increases, so diastolic filling time decreases, transmitral gradient increases, and that will increase the pulmonary venous and pulmonary capillary wedge pressure, causing the pulmonary edema. Now, Like you take any exertional activity, like the individual doing exercise, excitement, fever, severe anemia, development of paroxysmal atrial fibrillation, sexual intercourse, pregnancy, and as well as thyrotoxicosis. So any form of exertion, the individual will develop dyspnea. Whereas you take in case of severe mitral stenosis. In case of severe mitral stenosis, even the lesser degree of stress, right, even the lesser degree of stress, even this also will make the individual to develop the dyspnea, right? And not only that, whenever the individual does the daily activities, the activity of the individual becomes limited. Why? Because of the dyspnea. So initially, the clinical manifestations will be in the form of the paroxysmal nocturnal dyspnea. Later, the patient will develop orthopnea, and subsequently, the patient will develop dyspnea on exertion, and there will be dyspnea at rest. So this is how the progression of the symptoms will be there. Now, these patients with mitral stenosis, they develop atrial fibrillation. What is the cause for atrial fibrillation? Because of increase in your left atrial pressure to almost 25 millimeters of mercury, there will be increase in your left atrial thickness. So once there is left atrial thickness is increased, or there is left atrial hypertrophy, that left atrium is arrhythmogenic, and that arrhythmogenic left atrium will be like throwing the atrial fibrillation, and that is what is called persistent. There can be development of persistent atrial fibrillation. Thereby, the patient will develop palpitations, right? And the another important symptomatology is the development of the hemoptysis. Now, why is that there will be development of hemoptysis? Because of increase in your pulmonary capillary wedge pressure, there can be rupture of or there will be, right, there will be rupture of pulmonary bronchial venous connections. So because of rupture of pulmonary bronchial venous connections, right, that can make the individual to develop the hemoptysis. Okay, right. And the next important point that you have to understand is the pulmonary emboli. So this, okay, one more point, this hemoptysis, what does it tells you? It tells you that there is increased left atrial pressure. Okay, right. Next is the pulmonary emboli. The development of or the presence of recurrent pulmonary emboli, they are the one which will increase the morbidity and as well as the mortality in patients with the mitral stenosis. Okay, so these are the features that you will come across in severe mitral stenosis. But let me tell you few more pulmonary changes, right? What are the pulmonary changes that you will come across in severe pulmonary stenosis? First and foremost, the pulmonary vascular bed. So there is fibrous thickening of there is fibrous thickening of the walls of alveoli, fibrous thickening of the pulmonary capillaries. Right? So fibrous thickening of the walls of the alveoli and fibrous thickening of the walls of the pulmonary capillary, what that can occur in case of the mitral stenosis. And the next important change is the lung volumes and capacities. You take vital capacity, total lung capacity, right? Then maximum breathing capacity, then oxygen uptake. Everything will be reduced. Right? Everything will be reduced. Vital capacity, total lung capacity, maximum breathing capacity and oxygen uptake, everything will be reduced. Then what will happen to the pulmonary compliance? The pulmonary compliance will be decreased. Okay, why? Because of increase in the pulmonary capillary pressure, right? Because of increase in the pulmonary capillary pressure during exercise, this increased pulmonary capillary pressure that can cause compression on the pulmonary vascular bed or pulmonary structures, and that is the reason why the pulmonary compliance will be reduced. And not only that, these individuals, they are more prone for the recurrent infections. Okay, so development of infections like bronchitis, bronchopneumonia, right, bronchitis, bronchopneumonia and lobar pneumonia. So development of these infections can precipitate or can complicate the underlying features of the mitral stenosis. Why? The mechanism is very simple. Whenever there is development of infections causing fever, there can be tachycardia or there will be tachycardia. So once there is tachycardia, the ventricular rate is increasing. So diastolic filling time of the ventricle is decreased. So there is decreased diastolic ventricular filling, and thereby transmitral gradient increases, and that will cause increase in pulmonary venous, pulmonary capillary wedge pressure, causing pulmonary edema. Thereby the individual will develop dyspnea. So these are the pulmonary changes. So what will happen to the pulmonary vascular bed? There will be fibrous thickening. Vital capacity, total lung capacity, maximum breathing capacity and oxygen uptake will be reduced. Pulmonary compliance will be reduced, and these individuals, they are prone for infections, and infections can further precipitate or complicate the underlying untreated mitral stenosis. Next is the thrombi and as well as the emboli formation. Now, these patients, left atria is arrhythmogenic, right? There is development of the atrial fibrillation. So when there is atrial fibrillation, how much will be the atrial rate? The atrial rate will be around 300 to 400 per minute. So when atrial rate is around 300 to 400 per minute, what will happen to the intensity of your left atrial contraction? It will be a feeble left atrial contraction. Once there is a feeble left atrial contraction, there can be stasis of the blood, and that particular stasis of the blood is the one which is responsible for the formation of the thrombus. And this particular thrombus, it is formed and it hides in the left atrial appendage. So in a patient with mitral stenosis causing atrial fibrillation, what will be the site of thrombus formation? That will be in the left atrial appendage. Okay. Now this thrombus, it can rupture, causing embolism. Right? It can rupture, causing embolism. So what is that we are very much worried is, right, if this embolization enters into the important circulatory system, there can be development of cerebrovascular accident if the emboli enters into cerebral circulation. There can be development of myocardial infarction if there is the emboli entering into the coronary arteries. Okay, and this systemic embolization, it is seen in almost 10 to 20% of patients with atrial fibrillation secondary to mitral stenosis. Okay, and this systemic embolization is seen in which group of individuals? This is seen in individuals of age group more than 65 years, then in those individuals with reduced cardiac output, right, those with reduced cardiac output, they are at high risk of the systemic embolization. Okay, then now what will be the physical examination findings in patients with mitral stenosis? You take on inspection. See, on inspection, how will be the face of these individuals? There will be malar flush. Okay, so the differential diagnosis for the malar rash is systemic lupus erythematosus, and the other one is the mitral stenosis. So in case of the severe mitral stenosis, there will be development of the malar flush, right? And how will be the face and as well as the nose? There will be pinched and blue faces. Right, pinched and the blue faces. And how will be the JVP? JVP will be elevated. That happens only if there is development of pulmonary hypertension. So once there is pulmonary hypertension, that will increase the afterload on the right ventricle. Subsequently, it will increase the right atrial pressure, and thereby the JVP will be elevated, and you will have the prominent waves. Okay. So what will be that prominent wave? That is prominent A wave. Right. The A wave will be prominent. And next is, how will be the blood pressure in these individuals? Like, for example, you take in case of very severe mitral stenosis, the cardiac output is significantly reduced, so the systolic blood pressure will be reduced. But whereas in case of progressive mitral stenosis or severe mitral stenosis, where the cardiac output is being maintained normal, the systolic blood pressure will remain normal. Then upon palpation, right, you need to palpate the left parasternal area. So what is that you will observe in the left parasternal area is, there is parasternal lift. Why is that parasternal lift present? That is because of right ventricular hypertrophy, which is occurring secondary to pulmonary hypertension, right? And you will also be able to make out the presence of the diastolic thrill, right? What is thrill? Thrill is nothing but the palpable murmur, right? Palpable murmur is called as thrill, and this thrill, it is being felt at the apex. And what should be the position of the individual for palpating this thrill? The individual should be in the left lateral position, right? And where is that you need to palpate? You need to palpate at the apex. Okay, in the left lateral position, you have the presence of the diastolic thrill. Then coming to the auscultation. So if you take this auscultation, right, you should be knowing about, so what will be the abnormality in the S1, what will be the abnormality in S2, and what is the murmur, and what are the additional sounds that you will listen in mitral stenosis. So in mitral stenosis, one of the very important point is the S1, it will be loud. The S1 will be loud in case of the mitral stenosis. Why? Because of increased transmitral gradient. When the blood is moving from left atria to the left ventricle, the mitral valve leaflets, they move apart to a greater extent. And when they are recoiling back, they recoil back with greater intensity, and thereby you will have a loud S1. But the point is, what condition of the mitral stenosis? You will have a soft S1, right? The soft S1, it is present in case of calcified mitral stenosis. And why? Because in calcified mitral stenosis, the valve mobility will be reduced, and thereby you will have soft S1. Then you have what is called as the variable S1. So variable S1, it is present in case of mitral stenosis when it is associated with the atrial fibrillation. When mitral stenosis is associated with atrial fibrillation, then the individual will have variable S1. Now what is the reason? Because when there is atrial fibrillation, the pressure rise within the atria is different depending upon the atrial rate. So in certain beats or in certain contractions, the left atrial pressure is very high, and in certain contractions, the left atrial pressure is low. So that is the reason why the individual will have a variable S1. Now coming to the second heart sound. So in the second heart sound, the P2 will be loud. Why is that the P2 will be loud? Because of the development of pulmonary hypertension, the P2 will be loud. But this pulmonary hypertension is seen in case of very severe mitral stenosis. So in very severe mitral stenosis where there is development of pulmonary hypertension, in that scenario, you have a loud P2. Then what will happen to the A2 and as well as the P2 split? Right? The A2 and as well as the P2 split, it is narrowed. Right, it is narrow. I can explain you the mechanism. So the reason is that in patients with very severe mitral stenosis, the cardiac output is reduced. So once the cardiac output is significantly, what will happen to your left ventricular inflow in case of very severe mitral stenosis? Left ventricular inflow will be reduced because there is severe mitral stenosis. The amount of blood which is moving from LA to LV will be reduced. So once the LV inflow is reduced, what will happen to cardiac output? Cardiac output is also reduced. So once the minimal amount of blood, once it enters into the aorta, immediately you get the A2. And because of development of pulmonary hypertension, you will have an early P2 as well. And thereby you have a close split between A2 and as well as P2. Then the next important abnormality is in the diastole. See, you don't have much of the additional sounds between S1 and S2, but the entire problem is during the diastole. So during the diastole, you have the following additional sounds, right? What are those additional sounds? So here you have the S1. So between S2 and S1, in early part of the diastole, you have the opening snap. Right? And this opening snap, it is being heard immediately after A2. Now, why is this opening snap and why is that it is not seen in a normal individual? See, in case of mitral stenosis, the valves which are getting opened are thick, rigid mitral valves. So when these thick, rigid mitral valves are opening forcibly, that will give you an additional sound, and that is called as the opening snap. So opening snap is due to what? Opening snap is due to forcible opening of rigid, thick mitral valve leaflets. That will cause the opening snap. Now, this opening snap is being heard immediately after A2. So, this A2-OS gap, this will decide the severity of the mitral stenosis, right? That is, if the A2OS gap is narrow, right? If the A2OS gap is narrow, so that tells the individual is having severe or very severe mitral stenosis. And if the A2OS gap, if it is wide, that tells the individual has mild mitral stenosis. That tells the individual has mild mitral stenosis. So that is about the opening snap. And how is the pitch of the opening snap? The opening snap, it is a high pitched sound, and it is heard in the early part of the diastole. So that is the reason why opening snap, just remember, it is a diastolic sound, right? So what are all the various abnormal diastolic sounds that can be heard apart from opening snap? You take pericardial knock, which is heard in constrictive pericarditis. That is also a diastolic sound, right? Yeah. So these are some of the additional sounds. One is opening snap and the other one is the constrictive pericarditis, pericardial knock. And few more additional sounds that can be heard in diastole is S3 and S4. S3 and S4, they are also diastolic sounds which are heard in case of the heart failure. Then very important point of the discussion is about the murmur. Okay, so these patients, they have the mid diastolic murmur. So why is that? Because during the mid part of the diastole, the gradient reaches the maximum. So when the blood is trying to move from left atrium to the left ventricle, there is an obstruction, and this obstruction becomes more significant during the mid part of the diastole, and that will create a turbulence in the mid part of the diastole, and thereby the individual will develop a mid diastolic murmur. And this mid diastolic murmur, or you take this opening snap, they are being heard at the apex. They are being heard at the apex. And one more point you need to know is, what is the duration between the A2 and as well as the opening snap? The duration between A2 and opening snap, it is around 0.05 to 0.12 seconds. So closer is your A2OS gap, severe is your mitral stenosis. And the concept is very simple. Like, how can you substantiate this concept? Narrower is the gap, severe is your mitral stenosis. See, once you listen A2, right? A2 is being heard during which phase of the cardiac cycle? A2 is being heard during isovolumetric relaxation phase. Okay, right? That is being heard during isovolumetric relaxation phase. Now, after the isovolumetric relaxation phase, what is the next immediate phase in the cardiac cycle? That is first rapid filling. Okay, so first rapid filling, it occurs due to opening of the AV valves, that is tricuspid valve on the right side and mitral valve on the left side. Now, immediately after your A2, which is heard during isovolumetric relaxation phase, if the left atrial pressure is increased to 25 millimeters of mercury in case of very severe mitral stenosis, what the left atrium will do? Because of its very high pressure, the mitral valve, it opens early than compared to that of normal. Why? Because the pressure is very high. So when the mitral valve is opening early than compared to normal, so your opening snap, whatever you are hearing in very severe mitral stenosis, it will be very near to your A2. So A2OS gap will decide the severity. Narrower is the gap, severe is your mitral stenosis. Okay, right. Now let me discuss about this mid diastolic murmur. So if you take this mid diastolic murmur that you listen in the diastole, it is a low pitched sound. Whereas opening snap, it's a high pitched sound. Whereas this is a low pitched sound, and it is low pitched rumbling sound which is being heard with the bell of the stethoscope, and it is best heard at the apex at the height of expiration, because all the left sided sounds, they increase on expiration, okay, at the height of the expiration, and the individual should be in a lateral recumbent position, right? Lateral recumbent position. Okay, and not only that, this murmur is also accentuated by mild exercise, right? So even mild exercise will accentuate the intensity of this murmur. Okay, so please remember, it is not only the A2OS gap which will decide the severity of mitral stenosis, even the duration of the mid diastolic murmur, right? Even the duration of the mid diastolic murmur also will decide the severity of the mitral stenosis. So longer is your mid diastolic murmur, severe is your mitral stenosis. Shorter is your mid diastolic murmur, mild is your mitral stenosis. Okay. Then followed by that, in the later part of the diastole, you have what is called pre-systolic accentuation, PSA, that is pre-systolic accentuation. Now, why is that pre-systolic accentuation? You see, in the later part of the diastole, the event that happens is the atrial contraction, and that will contribute to the second rapid filling of the ventricle. Now, normally, if the mitral valve annulus is around 4 to 6 centimeter square, the left atria contracts and the blood will move to the ventricle that cause the second rapid filling. But here, what has happened to mitral valve? It is reduced to less than 2 centimeter square. So, now left atria, if it has to contract against that mitral valve which is less than 2 centimeter square, left atria has to contract very strongly to push the blood into the left ventricle, causing second rapid filling. So, because of stronger left atrial contraction, you will listen an additional sound, and that is what is called pre-systolic accentuation. And the later part of the diastole is just before the systole. That is the reason why it is called pre-systolic accentuation. So, this is about the auscultation in patients with the mitral stenosis. So, loud S1 more commonly, loud P2, closed split second heart sound, high pitched opening snap, low pitched mid diastolic rumbling murmur, then pre-systolic accentuation which is being heard in the later part of the diastole. Now, the another important points that you need to know is that if mitral stenosis, if it is associated with mitral regurgitation, then in such case, along with this mid diastolic murmur which is heard in the diastole, you will also listen the pansystolic murmur of the mitral regurgitation. You will also listen the pansystolic murmur of the mitral regurgitation. Okay, right. And in case of the very severe mitral stenosis, right, in very severe mitral stenosis, what are the other findings that you will see? In very severe mitral stenosis, what did we discuss? There is development of pulmonary hypertension. And because of pulmonary hypertension, you will have the features of the right heart failure. What are the features of the right heart failure? That is, the JVP will be elevated. Then, how will be the liver in these individual? There will be development of the hepatomegaly, and that too it's a tender hepatomegaly. And these patients, because of the development of portal hypertension, there will be also development of ascites. Right? There will be also development of ascites, and there will be also development of the pleural effusion. Right, there will be also development of pleural effusion. Okay, so these are the features of the right heart failure. Right, then now these patients with mitral stenosis, they can have the associated lesions. Right, what are those associated lesions? Let me take up one by one. So the associated lesions are, these patients, they can develop functional pulmonary regurgitation. Now, why do they develop functional pulmonary regurgitation? Because of pulmonary hypertension in patients with very severe mitral stenosis, the blood from the pulmonary artery will leak back into right ventricle, resulting in pulmonary regurgitation. And then you will listen an early diastolic murmur. And that early diastolic murmur, whatever you are hearing in very severe mitral stenosis secondary to pulmonary hypertension, that is called as the Graham-Steele's murmur. That is called as the Graham-Steele's murmur. And not only that, there will be also the development of the functional TR, and this functional TR will make the individual to develop the pansystolic murmur, right? Will develop what is called pansystolic murmur. And this Graham-Steele's murmur, please remember, which is being heard secondary to pulmonary hypertension, it is a high pitched murmur. Right? It's an early diastolic murmur and it is a high pitched murmur. And in tricuspid regurgitation, you will listen the pansystolic murmur, but it's functional TR. And this right-sided murmurs, either you take the early diastolic murmur of pulmonary regurgitation or pansystolic murmur of tricuspid regurgitation, they increase in intensity on inspiration, right? Once they increase in intensity on inspiration, that we call it as the de Carvalho's sign. That we call it as the de Carvalho's sign. Okay, and occasionally there can be silent mitral stenosis. Now, when is that there is development of the silent mitral stenosis? So, in case of very severe mitral stenosis, right, in case of very severe mitral stenosis, cardiac output is significantly reduced, right? And in very severe mitral stenosis, the blood which is moving from left atrium to left ventricle will be very minimal. right? The blood which is moving from left atrium to left ventricle will be very, very minimal, right? When the blood which is moving from left atrium to left ventricle is very, very minimal in case of very severe mitral stenosis, you don't listen any murmur, right? There is no murmur. Then we call it as the silent mitral stenosis, okay? So this will happen when the cardiac output is markedly reduced, right? But once the decompensation is resolved, then there can be appearance of the murmur. So silent MS means this will happen when the cardiac output is severely reduced and when the movement of the blood from LA to LV is significantly decreased, and that will cause the silent MS, okay? So these are the associated lesions that you will see in patients with the mitral stenosis. Now, like what is very important in the labs are, first line investigation will be definitely the 2D echo. Then the confirmatory investigation will be an invasive investigation, that is cardiac catheterization. And you also need to know about the other investigations like ECG, 2D echo, chest X-ray, what happens. So you take the ECG. So what is happening? The basic problem is in the left atrium. So once there is a left atrial pathology, because of the left atrial depolarization, what you get is a P wave. So you will have the P wave abnormality. So what will be that P wave abnormality? The P wave abnormality will be in the form of the P mitral in lead 2. Right? Not only in lead 2, actually we consider lead 2 as a rhythm strip. So that is the reason why this P mitral, right, is very significantly seen in case of the lead 2. So that means what will happen to the duration of the P wave? The duration of the P wave will be more than 120 milliseconds. You take in a normal individual. In a normal individual, the duration of the P wave is less than 120 milliseconds. But here, the duration of the P wave is increased where it will be more than 120 milliseconds. Okay. And you also need to know, right, what will be the distance between these two peaks. The distance between these two peaks, it should be more than 40 milliseconds. Right, the distance between these two peaks of P mitral, it should be more than 40 milliseconds. There is another criteria to call it as the P mitral. And what will be the changes of the P wave in lead V1? In lead V1, so in lead V1, the changes that you will observe is the early part of the V wave will be normal, but the later part of the V wave, it is like more deep and as well as wide. Right, it is more deep and as well as wide. So there will be increase in the P terminal force. Right, there will be increase in the P terminal force. Okay, so this component will be enlarged. Right, so that is about the abnormality of the P wave in case of the mitral stenosis. Whereas if there is development of the right atrial hypertrophy, when that can happen in case of very severe mitral stenosis, if there is development of pulmonary hypertension causing right ventricular hypertrophy, subsequent to right ventricular hypertrophy, there can be right atrial hypertrophy. Once there is right atrial hypertrophy, you know, there can be what is called as the P pulmonale. So P pulmonale is that where the amplitude of the P wave will be more than 2.5 mm in lead 2. The amplitude of the P wave will be more than 2.5 mm in lead 2. That way, if there is P pulmonale, that tells that the individual is having right atrial hypertrophy. Okay. Next, then how will be the QRS complex in the mitral stenosis? The QRS complex will be normal, right? There will be no problem with the QRS complex. Then these patients, whenever they develop right ventricular hypertrophy, that is the point when the ECG will show you the presence of the right axis deviation. Okay. And this is a complete ECG with showing the P mitral. Okay, you see here the P wave in lead 2. Right, it is M shape. And you take lead V1. In lead V1, you take the P terminal force. Right, it is wide and even deep. So these are the changes of the mitral stenosis. Right. Then, and what about the right axis deviation is not very significantly seen here. That means that this particular patient did not develop any pulmonary hypertension or did not develop any right ventricular hypertrophy, just develop mitral stenosis, that's all. Then What are the chest X-ray changes in patients with the mitral stenosis? Chest X-ray changes, I'll give you the list first, then I'll show you all the changes. So, there will be straightening of left heart border, right? There will be straightening of the left heart border. Normally, it is not straight. Then, there will be double density sign. I'll show you what is that. So, there is double density sign. Next, there is widening of carina, right? And there is posterior displacement of esophagus, right? There is posterior displacement of the esophagus. So, these are the important chest X-ray findings. And these patients, when they develop pulmonary edema, you can also observe the presence of the Kerley B lines. Okay, so that tells the presence of the interstitial edema. So, where you have the widening of the interstitial septa at the base of the lungs, right? This is what is your straightening of the left heart border. So, why is this particular straightening of the left heart border? That is because of enlargement of the left atria or left atrial appendage, and main pulmonary artery will become prominent, right? There will be prominent main pulmonary artery, that is because of the very severe pulmonary hypertension, and due to dilatation of the upper lobe pulmonary veins, right? Due to dilatation of the upper lobe pulmonary veins, all these will contribute to the straightening of the left heart border. Then, double density sign. So, you can just observe here very clearly that within the right parasternal area, you have two shadows. So, one shadow is here, this is left atrial enlargement, and this is another shadow which is the right atrial enlargement. So, this is what is called as the double density sign. And you are having the straightening of the left heart border. And what did we discuss? That you have the presence of the Kerley B lines, which is suggestive of the interstitial edema, right? And you have to remember one important point, that if there is presence of the Kerley B lines, what does that tells you? That tells you that left atrial pressure is exceeded more than 20 millimeters of mercury once there is presence of the Kerley B lines, okay, which is suggestive of your interstitial edema. And the next important investigation is the 2D echo. So, in 2D echo, like we see multiple things, right? So, whereas you take, this is parasternal long axis view, okay, this is like the lateral view. Okay, so here what you will observe is, this is the left atrium and this is the left ventricle. And you can see this is the mitral valve leaflet, which is being thickened and mobility will be reduced. And how will be the shape of that anterior mitral leaflet? That will be in a form of the hockey stick. So, you will have an hockey stick appearance of the anterior mitral leaflet, right? And this particular hockey stick sign in the 2D echo is seen in mitral stenosis, whereas hockey stick sign in the ECG is seen in patients with digoxin effect. Okay, so in the ECG hockey stick sign, digoxin effect. 2D echo hockey stick sign seen in patients with the mitral stenosis, that represents the limited mobility of the anterior mitral leaflet. Now, what all parameters we check in case of the mitral stenosis? So, the parameters completely differ depending upon the severity of the mitral stenosis. So, first and foremost, the mitral valve area. So, we do what is called planimetry. In the short axis view, we do what is called planimetry. I'll show you what is planimetry. In the short axis view, by doing planimetry, we will be able to make out the mitral valve area. So, in very severe mitral stenosis, the mitral valve area is less than 1 centimeter square. In severe mitral stenosis, it is around 1 to 1.5, and less than 2 will be progressive, less than 2 centimeter square will be progressive mitral stenosis. Then, what will happen to the pressure gradient? See, how much is the normal pressure gradient between the left atrium to the left ventricle? That is 0 to 5 millimeters of mercury. That is a pressure gradient between the left atrium to left ventricle. And in case of the very severe mitral stenosis, the pressure gradient, it will be increased to more than 10 millimeters of mercury, right? Whereas in severe mitral stenosis, it will be around 5 to 10 millimeters of mercury, right? Whereas in progressive mitral stenosis, right, it will be almost near to the normal, that is less than 5 millimeters of mercury. So in case of progressive mitral stenosis, we will not be able to decide progressive mitral stenosis based on the pressure gradient, because in progressive, it will be almost near to the normal. So how do you define progressive mitral stenosis based on 2D echo? That is by mitral valve area, which is being measured on the planimetry on the short axis view of the 2D echo. Then the pressure half time. What is pressure half time? That is the time which is required for half of the volume of the blood, right? It is the time required for half of the volume of the blood to move from left atrium to the left ventricle. That is what is called as the pressure half time. So how much is the normal pressure half time? The normal pressure half time when the mitral valve area is around 4 to 6 centimeters square, the normal pressure half time is around 40 to 60 milliseconds. Now, the point is, when there is development of mitral stenosis, the time required for the movement of the blood from left atrium to the left ventricle is increased. So the pressure half time is also increased. So pressure half time, which is normal around 40 to 60 milliseconds, in case of very severe mitral stenosis, it will be around more than or equal to 220 milliseconds. Whereas in severe mitral stenosis, it will be more than or equal to 150 milliseconds. Whereas in progressive mitral stenosis, the pressure half time will be less than 150 milliseconds. Okay, so this is about, these are all the parameters that we need to check within the 2D echo. Now let me show you the mitral valve leaflet position and all in the 2D echo. See, this is the rheumatic mitral stenosis. This is the two-dimensional transthoracic, which is directed M-mode echocardiography, right? So this M-mode, how it should be in a normal mitral valve leaflet. See, this is E slope of the mitral valve leaflet and this is A slope of the mitral valve leaflet. So we take what is called E by A ratio. So this is how the pattern of the M-mode should be there when you place an M-mode over the mitral valve leaflet. Okay, so right, this is where is your mitral valve leaflet. Okay, so at this point, you are applying the M-mode. So you get this E and as well as A slope. But in patients with mitral stenosis, you see, there will be flat mitral valve diastolic slope. You don't have this classical E by A slope, right? E by A, E pattern, A pattern, you don't have in mitral stenosis. Okay, so you have flat mitral valve diastolic slope and as well as thickening of the mitral valve leaflets. Okay, and this is the image showing three-dimensional transthoracic view of the mitral valve in mitral stenosis, which is giving you a classical fish mouth appearance. Okay, so funnel shaped mitral valve. Then the another important thing is you should be able to calculate the gradient. So how will you calculate the gradient? You have to apply CW, that is continuous wave Doppler, across the mitral valve orifice, right? Continuous wave Doppler across the mitral valve orifice in apical 4-chamber view. So, and you need to trace this particular graph. Once you trace this graph, then you get the gradient. You see here, so in this, the gradient is around 16 millimeters of mercury. So when the gradient is like 16 millimeters of mercury, what does that tells you? That tells you the individual is having very severe mitral stenosis. Okay, so you need to apply CW in apical 4-chamber view. Once you apply the CW, that is color wave Doppler, over the mitral valve in apical 4-chamber view, you get this pattern. Once you trace the pattern, then you get the gradient. Then yes, so this is about your planimetry. So planimetry you have to do in a short axis view, right? So you need to open the mitral valve in the mid diastole in the short axis view. Then you need to trace, right? You need to trace the opening here. Okay, once you trace the opening, you get the area. Okay, so that is about in mitral stenosis how to make out the mitral valve area. Okay, that is upon doing planimetry. And next is the pressure half time. So how will you make out the pressure half time is, you have that slope E and then slope A. So this is what is the pressure half time. How much is normal? 60 to 80 milliseconds. Okay. Now if you see here, it is around 168 milliseconds. So if it is 168 milliseconds, what does that tells you? That tells you it is severe mitral stenosis. Okay. In severe mitral stenosis, what is the valve area? 1 to 1.5. But if the pressure half time is like more than 220 milliseconds, then it is your very severe mitral stenosis. Okay. So this is about the importance of 2D echo in the diagnosis. And what is the confirmatory? It is an invasive procedure, that is cardiac catheterization, that will measure the pressure gradient across the mitral valve. And if the pressure gradient across the mitral valve, if it is increased to more than 5 millimeters of mercury, we can consider it as the mitral stenosis. Okay. And it will also tell you the left atrial pressure changes and left ventricular pressure changes by doing the cardiac catheterization, which is a confirmatory investigation. Okay. Coming to the treatment in patients with the mitral stenosis. See, the treatment completely depends upon the severity of the mitral stenosis, and treatment completely depends upon the symptomatology of the mitral stenosis. So now let me discuss the treatment in patients with the mitral stenosis. So to this particular table, we will come back to the last. This is the summary of the treatment of the entire severities of the mitral stenosis. So first and foremost, about the prophylaxis. See, what is the most common cause of mitral stenosis? That is the rheumatic fever. So, and this rheumatic fever, it's a recurrent inflammatory disorder. So you need to give the penicillin prophylaxis in individuals with active rheumatic fever, right? So those individuals who are at increased risk of the development of further complications, definitely you need to give the prophylaxis. And this prophylaxis, you have to give benzathine penicillin, and that has to be given, this benzathine penicillin that you are giving, it should be deep IM, right? Deep intramuscular route. And you have to give it for every 21 days. Okay. So that is about the penicillin. Then what about the infective endocarditis prophylaxis? And for how long you need to give penicillin prophylaxis and all, I have discussed in detail in the section of the rheumatic fever. Now what about infective endocarditis prophylaxis in case of the mitral stenosis? So those patients who has history of infective endocarditis, in them you need to give infective endocarditis prophylaxis. And in those individuals who have high risk for complications, right, who have high risk from complications or who have high risk of complications from infections, in them you need to give the infective endocarditis prophylaxis. But very important is in those individuals who have past history of infective endocarditis, in them you need to give infective endocarditis prophylaxis if the patient has developed mitral stenosis. Now, in symptomatic patients with mitral stenosis, what is the treatment that you need to give? So, water restriction and as well as the diuretics. Okay. So, what is the purpose of doing this water restriction and as well as the diuretics? Is that is mainly to reduce the pulmonary edema, and thereby the dyspnea can be resolved. Not only the water restriction, even the salt restriction has to be advised in this individual. So, water restriction, how much water? That is around up to 1 to 1.2 liters of water can be taken by the individual per day. And salt restriction, that is 6 grams of salt the individual has to take per day. So that will be the salt restriction. But this diuretics are the very important stay of the treatment for treating pulmonary edema, and the diuretics what we give is the furosemide. Now coming to the beta blockers, non-dihydropyridine calcium channel blockers, and as well as the digoxin. Now what is the purpose of giving these particular drugs is they are given mainly to reduce the heart rate. So what did we discuss? One of the very important factor which can assess the severity is the heart rate of the individual. If the heart rate of the individual is increased, like in case of atrial fibrillation or in case of anxiety or during exertional activity, what will happen? There will be decrease in the diastolic filling, causing increase in transmitral gradient, causing pulmonary edema. So in order to reduce the heart rate, we need to give beta blockers, that is cardioselective beta blockers in the form of metoprolol can be given. But if there is any contraindication to the beta blockers, the other alternative drugs will be non-dihydropyridine calcium channel blockers, and this non-dihydropyridine calcium channel blockers are diltiazem and as well as the verapamil. Right, and these beta blockers and non-dihydropyridine calcium channel blockers are also given if the patient with mitral stenosis has developed the atrial fibrillation. And digoxin is also the drug which is given when the patient develops the atrial fibrillation. So what digoxin does basically, digoxin will reduce the ventricular rate. So how it will reduce the ventricular rate? Digoxin will increase the refractory period at the level of the AV node, and by increasing the refractory period, the transmission from the atria to ventricle will be reduced. So thereby the ventricular rate can be reduced. So these are the drugs which will reduce the heart rate in an individual with atrial fibrillation, okay, which is very, very important part of the treatment in case of the mitral stenosis. Then the anticoagulants. The anticoagulants, if the individual is like admitted patient, you can give low molecular weight heparin, or if the individual is not admitted, then you need to give warfarin. And whenever you are giving warfarin, you need to maintain the INR of 2 to 3. Now, what is the purpose of giving this anticoagulants first of all? Because these patients, so you have to give in patients with mitral stenosis with atrial fibrillation, right? MS who have atrial fibrillation, you need to give anticoagulants because they are at increased risk of the formation of thrombus, and that can shower the embolism. So to avoid that, we need to give this anticoagulants. And those patients who have the history of thromboembolism, right, who have history of thromboembolism, in them also you need to give the anticoagulant. And you need to give this warfarin if there is the presence of the LA thrombus, right? If there is presence of the LA thrombus, then also you need to give this anticoagulants, okay? So basically, like your warfarin, what exactly is that? It is a vitamin K antagonist, right? And whether we are giving this NOACs, what are NOACs? These NOACs, they are apixaban, endoxaban, rivaroxaban and dabigatran. So until now, there are no particular studies showing the advantage of NOACs in case of valvular pathologies causing atrial fibrillation and preventing the thromboembolism, right? So NOACs should be avoided in case of mitral stenosis causing atrial fibrillation. What we give is the warfarin, okay? Next is about the cardioversion, right? So until now, like what we have discussed is the symptomatic treatment for dyspnea, that is water restriction, salt restriction and then diuretics. And then for palpitation secondary to atrial fibrillation, either beta blockers, non-dihydropyridine calcium channel blockers or digoxin. And to prevent this thromboembolism, we need to give the anticoagulants. Then next is the cardioversion. So cardioversion, whether to do the medical or pharmacological cardioversion or the electrical cardioversion, it completely depends upon the hemodynamic stability of the individual, right? If for suppose, if the individual is like stable patient, right? That means the individual is like hemodynamically stable, then you need to do pharmacological cardioversion in case of the atrial fibrillation. So cardioversion is basically done to stabilize the rhythm. In atrial fibrillation, you have irregular rhythm. So to revert back to normal sinus rhythm, you need to do pharmacological cardioversion, and that can be done with the help of the amiodarone, right? And if suppose, if the individual is like hemodynamically unstable, and one more point you need to understand that if these stable patients, if they are requiring electrical cardioversion, then what you have to do is you need to give 3 weeks of anticoagulants. After giving 3 weeks of the anticoagulants, then you have to give or you have to do electrical cardioversion. But for suppose you take an emergency scenario. In emergency scenario, you cannot wait like you cannot wait for 3 weeks by giving anticoagulation. So in emergency scenario, what you need to do is you need to give intravenous heparin, right? And you need to do a transesophageal echocardiography to look for the presence of any LA thrombus. And if there is no LA thrombus in transesophageal echocardiography, then you can do the electrical cardioversion in case of the emergency scenario, right? Now, in certain cases of the atrial fibrillation, the conversion will be unsuccessful, right? What are those scenarios where the atrial fibrillation irregular rhythm will not be converted back to normal sinus rhythm? You take in patients with very severe mitral stenosis where there is hypertrophied left atrium. In such case, the conversion becomes unsuccessful. Okay, right? So very severe mitral stenosis where left atrium is grossly enlarged. In these patients, the conversion will be unsuccessful, right? And the another important scenario is if the duration of the atrial fibrillation, if it is more than 1 year in a patient with the mitral stenosis, here also the conversion becomes very difficult. So these are the two scenarios where in spite of electrical cardioversion or pharmacological cardioversion, the conversion will be unsuccessful. So this is about the medical management. Now, next important thing that you need to know is about the surgical treatment in patients with mitral stenosis, and that is being done what is called as mitral commissurotomy. And this mitral commissurotomy can be done in two methods. One is percutaneous balloon mitral valvotomy, that is PBMC, or commissurotomy. Then the other one is the mitral valve replacement. Now, what are the indications for doing this mitral commissurotomy? The indications are if the individual is having very severe mitral stenosis and the individual is symptomatic, right? It is an indication for doing the mitral commissurotomy. Or if the individual is having severe mitral stenosis refractory to medical management, then that is also an indication for doing the mitral commissurotomy. Right? So, unless if the individual is not having any contraindication, then you can do this mitral commissurotomy. So, what do you mean by the word symptomatic? The individual should be having dyspnea, and that should be NYHA class 2 to 4. Right? NYHA class 2 to 4, the individual will be like symptomatic dyspnea will be there. So, it's an indication for doing commissurotomy. And the another important indication is the patient like refractory to medical management. Now, let me discuss about the percutaneous balloon mitral valvotomy or the commissurotomy. So, this is the preferred method then compared to that of the mitral valve replacement. Now, what we do in case of PBMC is that we take the catheter along with the balloon, we puncture the inferior or we puncture the femoral vein, right? And from the femoral vein, the catheter is passed to the IVC, inferior vena cava. And from the inferior vena cava, the catheter enters into the right atrium. And from right atrium, the interatrial septa is ruptured, right? So, that is, sorry, not ruptured, it is punctured. The interatrial septum, it is punctured, right? So, after puncturing of the interatrial septum, this catheter, it is brought across the mitral valve apparatus, right? It is brought across the mitral valve leaflets, and here it is inflated, right? And where there will be ballooning. So, what is the name of the balloon? The name of the balloon is the Inno balloon, right? The name of the balloon is the Inno balloon. So, once you dilate, the commissures which are like fused, that gets disrupted and the commissures, they open. Okay, so thereby there will be opening of the mitral valve by doing the percutaneous balloon mitral commissurotomy. Now, there are certain contraindications for doing this PBMC. If the individual is having calcified mitral stenosis, then it's an absolute contraindication. If there is presence of LA thrombus, then that is also contraindication for the PBMC. Then if mitral stenosis, if it is associated with moderate to severe mitral regurgitation, right, then also it's a contraindication for percutaneous balloon mitral commissurotomy, right? And yeah, so these are the contraindications for PBMC. So in all these scenarios, if you want to do the intervention, what you have to do is mitral valve replacement has to be done. Right, mitral valve replacement has to be done. Now, why is this PBMC more preferred than compared to that of the mitral valve replacement? Because this PBMC, it is associated with less morbidity, right? And it is also having a minimal peri-procedural mortality rate. So, they also have less peri-procedural mortality rate. Okay, so that is about your PBMV, percutaneous balloon mitral valvotomy. Then coming to the mitral valve, okay, so this is one of the graph showing the mitral valve apparatus or the mitral stenosis pre-dilatation and as well as the post-dilatation. You see here. So this is the graph of the left atrium and this is the graph of the left ventricle. And you see the pressure gradient between the left atrium and left ventricle. The pressure gradient is around 15 millimeters of mercury. Right? Now after post-dilatation, you take the pressure gradient between the left atrium and left ventricle, that is around 3 millimeters of mercury. Okay, so this is the graphic representation of the gradient between the left atrium and as well as the left ventricle before and as well as after the dilatation. And one more important point, we have a scoring system that is called ECO score. This particular ECO score has been developed to guide the decision making, whether to do percutaneous balloon mitral commissurotomy or whether to do mitral valve replacement. Okay, so what is the name of this particular ECO score? This name of the ECO score, it is called Wilkins score. Now, what are the parameters that we take in the Wilkins score? So there are totally 4 important parameters what we take in the Wilkins score. One is the leaflet mobility, valve thickness, leaflet calcification, then subvalvular thickening. And I have just given you a table here. If nothing is there, the score is 0, right? And if the individual is having high leaflet mobility with only leaflet tip being restricted, give a score of 1. And near normal thickness around 4 to 5, give a score of 1. Single area of echo brightness, that means there is calcification, give a score of 1. Minimal caudal thickening just below the leaflet tips, give a score of 1. So depending upon the severity, we give a scoring of 1, 2, 3, 4. If the score is less than or equal to 8, he is an ideal candidate for the PBMC or PBMV. But if the score is like more than 8, then PBMV should not be done. What you have to do is mitral valve replacement has to be done. So that is about your ECO score, which we also call it as the Wilkins score. Now let me discuss about the mitral valve replacement or open mitral commissurotomy. So what is the indication? Number 1, the Wilkins score more than 8. Then calcified mitral stenosis. So whatever the contraindications are there for PBMC, all that will be the indication for the mitral valve replacement, right? The presence of the LA thrombus, right? The presence of the LA thrombus. And the another very important indication is the presence of MS with moderate to severe MR. That is another important indication. Now, let me discuss about the mitral valve replacement or open mitral commissurotomy. So, what should be the approach? Like, you need to cut open the chest, that is using cardiopulmonary bypass, right? Using cardiopulmonary bypass, you need to do the open mitral commissurotomy or the mitral valve replacement has to be done. Now, whenever you are doing this open mitral commissurotomy, it is not that you need to concentrate only on the mitral valve leaflets. Okay. So, you also need to loosen the subvalvular fusions. If there is any fusion in the caudate tendinae, if there is any fusion in the papillary muscles, and you also need to remove the calcium. So, the concept of the open mitral commissurotomy is not just only correcting the leaflets. Even subvalvular fusion and subvalvular calcium has to be removed. And if there is any atrial thrombi, even that also has to be removed. But by doing this mitral valve commissurotomy, the perioperative mortality rate is around 2%. Right? Perioperative mortality rate is around 2%. But these patients who have undergone this open mitral commissurotomy or surgical mitral commissurotomy, there can be restenosis, or these patients, they require reoperation after 10 years. Right? They require reoperation after 10 years. Okay. So now what are the parameters that tells that there is successful commissurotomy? First and foremost, the mitral valve gradient. mitral valve gradient, it has to be reduced by almost 50%. Right? Mitral valve gradient, it has to be reduced by almost 50%. Like for example, before doing the mitral commissurotomy or mitral valve replacement, if the gradient was 10, now the gradient should be 5. That tells that there is the successful commissurotomy has been done, right? And what should happen to the mitral valve area? There should be doubling of the mitral valve area, and there should be clinical improvement. That means the dyspnea or the palpitations, whatever are there, that should be completely resolved. So not only clinical improvement, even hemodynamic improvement also should be done. Right? So this tells that the individual had a successful commissurotomy. Right? Next important is, how do you treat the mitral stenosis in pregnancy? So definitely yes, medical management, that will be the first line management, that will be in the form of diuretics and beta blockers. But if the individual is refractory to medical management, the preferred procedure is the PBMC. But when you are doing PBMC, you should not do PBMC under the cardiac imaging. You have to do PBMC with the help of TEE, that is transesophageal echocardiography. But if you do in a cardiac cath lab, like what can happen? There is risk of, the radiation to the fetus. So that will be teratogenic. So that is the reason why you have to do PBMC with the help of transesophageal echocardiography, right? And if the candidate is not fit for PBMC because of calcification or thrombus or presence of associated MR, then she has to undergo the mitral valve replacement. Okay, right. So now what are the mortality rates after the mitral valve surgery? So if you have done mitral valve replacement isolated, mortality rate is around 4.5%. Along with mitral valve replacement, the patient has also undergone CABG. The mortality rate is around 10%, that is 9.6%. And if it is mitral valve repair, mortality rate is like 1.2%. Mitral valve repair plus CABG, mortality rate is around 5.4%. So overall, peri-procedural mortality rate is around 1 to 10% depending upon what the procedure is being done. Then overall, how is the prognosis in patients with the mitral stenosis? See, overall 10-year survival, right? Overall 10-year survival in surgical candidates is around 70%. That means in those individuals who have undergone surgery, the 10-year survival is around 70%. And the long-term prognosis completely depends upon the age of the individual. So if the age of the individual is around like more than 65 years, the prognosis is not that good, right? And if there is depressed cardiac output or if there is depressed ejection fraction, then also the prognosis of the individual is not good. And next is the development of other complications like pulmonary hypertension and as well as the right ventricular failure. So development of pulmonary hypertension and right ventricular failure, they are not at all ideal prognostic factors for mitral stenosis. Okay, if there is development of pulmonary hypertension and right ventricular failure, the prognosis is bad. Okay, right. Then summarizing the entire mitral stenosis, these individuals, they present with fatigue. Why is that? That is because of decrease in cardiac output. They present with exertional dyspnea. That is because of decrease in pulmonary compliance or pulmonary edema. There will be orthopnea, that is again because of your pulmonary edema, and these symptoms, they are precipitated by atrial fibrillation or any condition which will increase the heart rate, and it is also precipitated in pregnancy. Why? Because there is increase in fluid volume, there is increase in transmitral gradient, and there can be development of pulmonary edema. So the interventions indicated for symptoms, atrial fibrillation or evidence of the pulmonary hypertension. The interventions include PBMC or the mitral valve replacement. Most symptomatic patients have the mitral valve area of less than 1.5 centimeter square. What does that mean? Severe mitral stenosis. Whereas progressive mitral stenosis, that is in between 1.5 to 2 centimeter square, those individuals, they are mostly asymptomatic. So this finishes the very important topic, that is mitral stenosis. Thank you very much.